just I go back just a little for S-PESI, because simplified PESI, conversely to the STR rule, is a mortality risk assessment model. So, meaning that patients with a score to 0 points have a low risk of death. That's it. That's all. And what was our main findings? That the safety to triaging patients using the STR rule was at least, it was non-inferior than the safety to triage patients with S-PESI. The rate of adverse events at 30 days was near the same in the overall populations. What we mean by adverse events: recurrence of VTE, major bleeding, or all-cause death. Okay, so no difference in the overall populations without the two triaging rules.
And now for you guys, I know when I was just looking at sort of the trial design, I think there's a dozen secondary endpoint measures that were included in the study. I'm not going to ask you to go through each one of them. Are there any that?
The second result was the rate of patients treated at home with each rule. So we find no statistically no difference between the two rules. More than 1/3 of patients were treated at home with either the STR rule and the S-PESI. And importantly, the rate of adverse event in patients treated at home was similar and very low in both arms. No VT, no PE recurrence, no deaths related to PE in either arm. So that was very important. So we can use either the S-PESI, either the STR rule. We can treat at home at least 1/3 of the patients with a very low risk of complications. That was our main result. However, the two rules are not used in the same way. For example, when we used S-PESI, the physician have to perform a complementary assessment of the suitability of patients for home treatment. So in many times, for 29% of the patients, the physicians, for patients who were qualified for home treatment because they have a S-PESI score to 0, the physician considers that this patient require hospitalization because they have, for example, an underlying disease, they have a high risk of bleeding, so they can be managed at home, even if the score was 0 points. So when we use S-PESI, you need to perform an overruling of the qualifications. When we use STR, we can use STR alone. I think with two important notions to take into account. First, for all these patients, they were at the first level managed in the hospital, in the emergency department, to have assessment of the diagnosis and assessment of the risk of pulmonary embolism. And most of the time, we have 24 hours of observation of this patient in the hospital before they were discharged to home. That's the first notion. The second notion was in all of the hospitals participating to our study, they have, before the beginning of the study, put in place a specific pathway for home treatment of patients with a dedicated team who performs the follow-up of the patient. And we can perform a phone follow-up in case of complication. I don't know if I was very clear, but
yeah, no, that's fine. I get what you're saying. Was there anything else before I let you go that you think might be important to mention when discussing your study?
I think that as today there is around, at least in France, and I think in the USA is the same thing. There is around 90% of patients with acute PAs who are hospitalized. So if we applied either the STR rule or the aspect to treated patient at home, it will be really, really cost savings. And I think it would be fine for many patients. So I think our research adds high level of evidence of current guidelines for home treatment of patients with acute pain.